Why are geriatric patients a special category in trauma patients? Basically, the answer is as the age increases, there is a loss of brain matter that is replaced by CSF. Also, dura matter becomes tight to the skull and thus creating a space in the cranial cavity. Thus, when the acceleration and deceleration injury occurs, brain has a larger space to move. Also, stretching of the parasagittal sinuses, bridging veins may lead to shear injury. Cerebral blood supply reduces because of atherosclerosis, leading to subtle changes in mental status and demyelination. Also, medical comorbidities and their treatments may alter the consciousness level. Visual and auditory, as well as joint position sense vibration, may be impaired, making them prone to injury. In the spine, there is also a loss of hydration of intravertebral disc, leading to disc desiccation. Thus, the loads of weight transmission is shifted to the facets, ligaments, and the paraspinal muscles, leading to degenerative overall picture of spinal canal stenosis. Also, because of the segmental immobility, a cord injury is common. Those elderly patients on anticoagulants are more prone to hematomas even after minor head injuries. Thus, coagulation profiles need to be reset. These hematomas cause neurological decline and may be the cause of future hematomas. CT brain is an investigation of choice in these individuals. The presence of cervical spine injuries are often complicated with pre-existing spine pathologies of degeneration and instability, making it further prone to injury. CT scan is done to look for the status of vertebrae, while an MRI is done to look for the cord status. Elderly patients are more prone to hypothermia as the skin loses its proliferating abilities. Thus, the thermoregulation is impaired, making an individual more prone to hypothermia. However, other causes of hypothermia should be ruled out, like infection, endocrine diseases, and side effects of antihypertensive medicines like beta blockers. Also, the overall musculoskeletal system is affected. Ligaments, cartilage, joint capsules harden with the passing of age, making it more prone for injuries. Also, because of lack of growth hormones present, physiological muscle mass reduces by 35%. Thus, we encounter difficulties when these patients are made to perform physiotherapy soon after their surgery. Also, even old patients do suffer from osteoporosis. This makes them more prone for certain type of fractures like collisus fracture, intertrochanteric fractures. If the fractures are overdiagnosed, if they are diagnosed on X-rays, an orthopedic consultation must be done for those patients. Every attempt should be made to stabilize the fracture as soon as possible, also as well as early mobilization. Coming to nutrition, there is always an important facet in the management of elderly patients and often overlooked. With advancing age, the metabolic requirement reduces and they tend to starve. Their dietary requirements increase after surgery, which are not met with, and that leads to further reduction in muscle mass. Also, with the increasing age, there is an compromise on the immunity, and certain chronic diseases may cause an impaired cell-mediated immunity. Thus, generalized response to sepsis, such as fever, leukocytosis, inflammatory cells, are poor. Thus, it is seen that even minor trauma that cause great disability and management of blood loss due to the fractures, and they must be clearly monitored. Epidural catheter placements are contraindicated in the patients with anticoagulants. However, administration of fresh frozen plasma help to counteract the effect of anticoagulants. Drug interactions that are a common issue that are less dealt with owing to a narrow therapeutic range in elderly. Also, some side effects are pretty common in elderly that may interfere with shock management. Beta blocker limits the cardiac activity, and calcium channel blockers impair the blood vessels to function to vasoconstrict. That itself may lead to hypotension. Non-steroidal anti-inflammatories interfere with platelet function. Steroid further reduces the inflammatory response. Chronic use of diuretics also may cause reduction of blood volume with hypokalemia. Psychiatric medicines cause a a greater effect if they are stopped abruptly. Antiemetics may cause Parkinson-like symptoms. Antibiotics are ototoxic and nephrotoxic. Thus, a clinician should always take a drug history and titration doses accordingly. Thus, bringing an older individual to a pre-functional status is always a challenge and requires proper knowledge regarding the anatomy and physiological changes that take place. Knowing the implications of the comorbidities, drugs should be administered, and their side effects and interactions are should be known very thoroughly. And with this, we come to an end to one of the most important modules on the geriatric trauma. If you have any queries, insights or experiences, please feel free to write in the section below. If you like this video, give a thumbs up or subscribe to our channel for more of such videos.